as Dave alluded to, we've gotten into a lot of trouble with the way we've been doing PSA testing over the last 15 to 20 years. So here's the first question I'd like to pose to you. What is the most common age stratum of men in the United States who are getting a PSA test? Is it men between 45 and 50, 50 and 55, 55 and 60, 65 and 70, or 70 and 75? So if you could just vote for the group by 5-year age stratum that you think is most likely to be tested with PSA. Well, I'm going to show you that it's actually men between the ages of 70 and 75, and that's been a huge part of the problem. And it's not urologists doing it, mind you. As we heard, it's probably more likely our family doctor internist colleagues. How about the next question? The 2015 NCCN recommendation for biopsy, to consider biopsy, is a PSA level of 2 or 2.5, 3, 4, or it should be age adjusted. Just the latest NCCN guideline. Well, no, that's not true there. Well, in some sense it is, but you'll see later on that it's actually at 3. But so we have some new information to pass along. Since this is a CME, here are my disclosures. You can see the various companies and the 2 institutes from the National Institutes of Health. I'd like to give an overview of screening. I'd like to talk at a high level about the results of the big randomized trials, and then review some of the specialty guidelines. And I actually won't be touching this because many of the later speakers will be going into a lot of this in a lot more detail than I can. So here's the top-level summary of, I think, where we stand. You know, based on what we've been doing, mass screening on the basis of age alone has a small effect on prostate cancer mortality. It's either somewhere between a 0 and a 0.9 absolute risk reduction. In other words, the average U.S. man has about a 3%. If you put in some of the best results, you can lower that chance of dying of prostate cancer down to 2.1%. As we'll show, PLCO didn't show a benefit. ERSPC did show a 20 to 30% relative risk reduction in a subgroup. There's certainly some limitations to that trial as well as PLCO, and we'll talk about those. But the real problem, as we've talked about for the last couple of years, has been a significant risk of overdiagnosis and a significant risk of overtreatment. And those are the things that have really hampered us. And you know, there are a lot of factors that promote the overdiagnosis of prostate cancer. And this was a nice review article by Gil Welch a few years ago. And I put it to you that prostate cancer really could be the poster child, because it does fulfill each one of those factors that promote the overdiagnosis of a cancer. But I want to say it's not just prostate cancer that when you screen for it, you overdiagnose. It's true for thyroid cancer, it's true for breast cancer, and it may be true for some of the other cancers as well. And recently, NCI, in conjunction with Oxford, had a 3-day conference on how to minimize the overdiagnosis of prostate cancer. So everybody knows there's a huge reservoir of prostate cancer just waiting to be discovered by the process of putting a needle into the prostate. You can see the relatively high rates of cancer in both black and white men. And a little bit underappreciated, it's even true in Asian men. There's a very fine study from Alex Lotta that came out a year or 2 ago that notwithstanding a very low death rate from prostate cancer, there's a pretty high autopsy rate of prostate cancer in Asian men. In this case, it was Japanese men. And when you sort of crunch the numbers, as Vickers is known to do, he took data from the PCPT trial where there was annual repeat screening and based only on sextant biopsy. If you bootstrap that analysis and consider only men who started out with a PSA of less than 1, after 25 years, you would have found 3 times as many cases of prostate cancer as you would have expected to be clinically diagnosed. We would have found 21.6 times as many cases as men would have ever developed metastatic disease. And you would have found 65 as many cases for every man who actually died of prostate cancer. So there's a real great opportunity with serial PSA testing and even just a crummy sextant biopsy to overdiagnose prostate cancer. But as I said, it's not just prostate cancer. Here's a summary of what's been going on with mammogram-based screening for breast cancer. You can see a high rate of false positives, unnecessary biopsies, and 57 out of the 302 cases were considered to be overdiagnosed. And that's despite the fact that the mortality benefits of mammography are really not well established. Here's a recent summary showing that when you look at different counties throughout the United States, the more mammograms that are done in the county increases the incidence of the disease, but it really doesn't change very much the breast cancer mortality. And David also already showed this slide that mammography, as presently practiced, is unable to reduce the incidence of metastatic disease, whereas we certainly know that PSA testing can. I mentioned to you about thyroid cancer. The Koreans are doing an experiment right now. They started screening with ultrasonography for thyroid cancer, and you can see how they've increased the incidence of that disease. This is what is happening in the United States, where there's no organized screening. But here is the mortality from thyroid cancer, well below 1.1% in both of those countries. So if you start looking for cancers, you're going to find them. And the problem with overdiagnosis, as we all know, is that it ruins people's lives. And in the case of prostate cancer, this study from a number of years ago showed that even men without a history of cardiac events, within a week or a month after being told they had prostate cancer, had between a 3- and a 4-fold increased chance of sustaining a major cardiovascular event. So the message we give over the phone that this is a toothless lion, don't worry about it, isn't being translated to the patients, but even an increased risk of suicide in the next 30 days after a prostate cancer diagnosis. These are some studies from the ERSPC that Fritz Schroeder published a year ago, showing that there's nothing we do in screening for prostate cancer that improves a man's quality of life. In comparison to the control group of ERSPC, the screen guys were a lot worse. The only time they got better was if you prevented the institution of endocrine therapy. And every step along the way prior to that only ruins a man's life. And this is why the World Health Organization, a number of European societies, and there's probably some American societies, have started the Choosing Wisely campaign. Think twice before you embark upon cancer screening. What about activities that have been happening in the United States? This is an advertisement from Kaiser a few years ago showing that 76% of Medicare-age men were getting screened. Here are data across the United States between the years 2000 and 2005, and this is where you see the group most likely to be screened were men in their early 70s. And you would say, well, we didn't know what we were doing then, we're a lot smarter now. And the answer is we're not, because here was an analysis that appeared late 2014 showing that among men over the age of 75 years, the frequency of screening actually increased between 2005 and 2010. And furthermore, the stunning thing was that if you looked at men who had a high risk, more than a 50% chance of dying within the next 5 years, half of those men had had a screening PSA within the last 2 years. And these are behaviors not probably by urologists, but by our colleagues. And just remember, the one study that shows a survival benefit for treating prostate cancer is a radical prostatectomy in the SPG4 Scandinavian study. That benefit accrued to very young men under the age of 65 who had clinically detected cancers. And remember, screen-detected cancers are usually 4 to 6 years, or discovered 4 to 6 years before they're clinically discovered. So we're clearly screening way too late. And this has gotten the attention of people who pay the bills. Measuring low-value care and medicine, $447 million annually spent screening men over the age of 75. And that's why there's a number of proposals out there to measure the quality of a physician. This is from HEDIS, saying non-recommended PSA-based screening, percentage of men 70 years older who are screened unnecessarily using PSA. For this measure, both measures, a lower rate indicates a better doctor. And that came out in March of 2015. Towards the fall, I'm sure we're all aware that CMS also made a recommendation or a survey not recommending PSA-based screening for men who are Medicare eligible. And finally, prostate cancer does have a long natural history. When you look at the big trials for screening or treating prostate cancer, you know what? Not many of the men actually go on to die of prostate cancer, irrespective of which arm they're in. Even when you look at the best, small study out there, the Göteborg trial, If you screen 1,000 men for 14 years, you help 5 of them. There's a number of them who still go on to die of prostate cancer, but along the way you've discovered 127 of them to have prostate cancer. And this is the summary statement from the National Cancer Institute that was used by the U.S. Preventive Services Task Force, sort of trading off the bad news against the potential good news of saving somewhere between 0 and 1 life per 1,000 men between the ages of 55 and 69 who are screened for a decade. And that's the cusp of the matter here. I'd just like to roll through a few of the salient points about PLCO. I should say the much criticized PLCO trial. It's true, there was a lot of pre-screening before the men enrolled. There was contamination in the control arm, so 85% of the men who should have been screened were, 42% of the men who shouldn't get screened were. The group that volunteered for PLCO was a very, very healthy group. But I want you to remember this slide. It's very busy, but it shows you that the men diagnosed with cancer in PLCO were treated evenly, whether you were in the control arm or the screened arm. And that's going to be an issue when we review quickly the ERSPC. You can see that after 13 years of follow-up, there were only half as many deaths from prostate cancer as we had anticipated when we designed the study. Now, those are appropriate criticisms of PLCO. There's been a ton of inappropriate criticisms of PLCO. Low biopsy rate, delayed biopsy missed the chance for cure. The thing that was good about PLCO is that it was a real-world study. We did the DREs and the PSA and reported them back to the patient and the primary doctors. They made the decision whether any further evaluation was necessary. And that's very different from ERSPC, where everything was basically done by urologists and done at urological centers of excellence. So if there was such a low biopsy rate in PLCO, why is the rate of prostate cancer discovery higher in both PLCO arms than certainly the control arm of ERSPC? That's because we did a lot of biopsies in PLCO. And remember, the death rate from prostate cancer in PLCO was 30% lower than the death rate in the screened arm of ERSPC. So if PLCO was such a lousy study where we didn't biopsy patients and we ignored their PSAs, why were these very favorable mortality rates and death rates observed? What are the criticisms of the ERSPC? You know, there were different cut points for biopsy. There were different screening intervals. But the big difference was that if you were randomized to be screened, you came to a center of excellence, whereas if you were not screened, you probably didn't even know you were in the study and you were treated in the community. The NCCN Briefing document, I think, put it nicely. The potential shortcomings of ERSPC included a lack of screening on all-cause mortality, over-reliance on secondary analysis, adjusting for noncompliance, because they had the same noncompliance rate in the screening arm. And finally, unbalanced treatment differences between the study arms. And there are other criticisms that you could point to. The big one in my mind that concerns me is that the finish arm of the ERSPC is the largest component of the ERSPC. It was actually slightly bigger than PLCO. They had 80,000 men versus 76,000. They had many more deaths from prostate cancer, 415 versus 174. Now, one of the smallest components was the Swedish or Gothenburg arm, which only had 20,000 patients in it. So now you have 2 different sites within the same trial. One of these sites is 4 times the size of the other. Now, you have the smaller site showing a large benefit to screening. You have the larger site showing no benefit to screening. So faced with those 2 things, which are you apt to believe? The smaller site result or the larger site result? And the other thing is that if you rank order mortality from prostate cancer among the various countries shown here, Sweden, Finland, and the Netherlands have the highest mortality from prostate cancer. It would have been nice if the high-risk, the high-mortality countries all showed a benefit to screening, which unfortunately they did not. But the big problem here is how the patients were treated. When you adjust these patients by the D'Amico risk classification, Statistically significant treatment differences at the 0.05 level were seen in each one of those arms. But the big one that I think is here, the men with high-risk localized disease, if you were in the screened arm, you had a 34% chance of a radical prostatectomy, only a 20% chance if you were in the control arm. And that's the one treatment we know that works. Whereas if you had high-risk localized disease and you were treated in the community, 30% of the time you only got hormonal therapy, whereas that occurred in only half as many patients who were in the screened arm. And as I mentioned before, treatment location differed. Screened patients were 6 times more likely to be treated at large academic medical centers. So therefore, these screened men likely received more aggressive and better radiation therapy and more aggressive treatment for hormone-relapsing disease. And we know that those can make a difference in prostate cancer mortality. And why is everybody concerned about that? Well, remember, mortality rates in the United States started decreasing in the early 1990s. Screening didn't even start until that time. So the mortality reduction that we see had to be due to treatment. And if you look back, the radical prostatectomy rates for Medicare beneficiaries increased more than tenfold between 1980 and 1990. And that's because of Dr. Walsh's anatomic radical prostatectomy. One thing I'll ask you to do is keep your eye out. There's a nice paper coming out that Ruth Etzioni is writing that's going to be a combined analysis of all the patients in PLCO and ERSPC. And I think it'll make a lot more sense when you look at the data that way. Everybody knows about the U.S. Preventive Services Task Force. I just want to touch on a few of the other guideline recommendations. Early detection reduces the risk of being diagnosed with metastatic prostate cancer. We already talked about that. Here are the real-time data from the ERSPC. Here is what happened in the United States when PSA screening started in the early 1990s. You can see very large drops in prostate cancer mortality. How about this idea of an early-in-life PSA? PLCO doesn't get credit for this, but Dave alluded to it, that the first publication on the fact that if you had a very low PSA and that conferred a very low risk of aggressive prostate cancer in the next decade started in PLCO. And then it was observed also in the ERSPC, where if you start with very low PSAs, you have to screen an enormous number of patients and treat an enormous number of patients to prevent one death. And then, of course, there was the Malmo preventive trial, which showed the value of getting early-in-life PSAs, and the statement that if you have 3 PSAs less than 2 up to the age of 60, you should be exempt from screening. This is corroborated to some extent by the U.S. Physicians' Health Study. Mark Preston and his team reported this recently in the Journal of Urology. And there's a study going on evaluating that. The AUA recently changed the guidelines, as you know, and recommends screening for men between 55 and 69, but again, stipulating that there's a fairly small benefit. The AUA is recommending to reduce the harms of screening an interval of every 2 years. Here are the NCCN guidelines recommending starting around the age of 45. If your PSA is greater than 1, frequent testing. If it's less than 1, less frequent testing at every 2 to 5 years. When you have a PSA of greater than 3, you should consider having a biopsy, or you should consider having some of these reflex tests, such as free PSA, OPCO-4K, or PHI. And I just want to talk a little bit about OPCO-4K, looking at the ERSPC, looking at the Malmo data. If you had a PSA of greater than 2 at the age of 60, you were considered at relatively high risk and you should be screened. But if you also know that man's OPCO-4K score, about half of those men would be reclassified as having low-risk disease and therefore would need less aggressive screening. I apologize for this. We just did an analysis that we'll present at the AUA in the PLCO trial, showing that if we had known OPCO-4K scores, we could have reduced biopsying about 35% of the patients, and we would have missed diagnosing about 1 or 2% of the high-risk cancers. So that really would have saved a lot. So in summary, I think PSA-based screening can, in fact, reduce prostate cancer mortality. It's not right to just screen men on the basis of age. Risk-adapted screening starting at an early age in life is good. But as we'll hear later on, there's no doubt that new markers and better biopsy is really going to turn the tide in our favor.